presentation for me last year at Indore, so I bring it for him again this year. May I have the video, please?
Thank you so much. So I'll be talking on scleral tunnel making and its principles. The first self-sealing incision was mentioned by Kratz et al. In 1980, followed by McFarland et al. In 1990. They described sutureless incisions. And Dr. S.L. Palin invented the first chevron incision, and Dr. J.A. Singer introduced the first frown incision. This was a brief introduction about the self-sealing incisions. Now, what exactly is a self-sealing incision? It's a triplanar incision which closes on itself with the help of intraocular pressure. Basically, this is the trapdoor effect. So, this is a self-sealing incision. Now, to make a self-sealing incision at the level of cornea, limbus, or scleral, you need to know the anatomy of the limbus, the posterior limbal border, mid-limbal line, and anterior limbal border. A reliable self-sealing incision should have a square incisional geometry, relatively short external incision with a tunnel that flares to a larger internal incision for the engagement of the nucleus, and geometric external incision shape that lends itself to stretching. And this is where Dr. Blumenthal's radial cuts come into significance. Now, these are the aspects of a sclerocorneal tunnel: its size, shape, location, width, depth, and entry into the anterior chamber, the depth in the cornea. These are the 6 points which one should always remember before starting to dissect a sclerocorneal tunnel. The instruments required for a good incision are conjunctival scissors. They should be sharp enough. They should not be blunt. Castroviejo's calipers. Please make it a habit to measure all your incisions. 15 number Bart Parker blade or blade fragment with a holder, and that should be sharp enough, not to give a ragged incision. Angled crescent blade, 3.2 millimeter angled keratome or a 5.2 millimeter tunnel incision and larger. These are the various types of incisions. We have seen smile incisions, straight incisions. Most commonly used are now frown, chevron, and U-shaped incisions, or a straight or frown with radial cuts, because of the because these are the incisions that limit your surgically induced astigmatism. Now, a scleral incision, this is how I design it. The distance from the center, distance between the center of the tunnel and the limbus is around 2 millimeters. Depending on how much SIA do I want from that incision, the length of the tunnel varies from 3 millimeters to 7 millimeters, although Dr. Sahu sir is now post-graduated to 2 millimeters also. The length of radial cuts should be between 1.5 to 2 millimeters. The radial cuts, if fashioned, they should be perpendicular to the limbus. If they are not perpendicular to the limbus, they are going to add up to SIA. If they are perpendicular to the limbus, they are not going to add up to the SIA. The depth of the scleral incision should be half the thickness of the sclera. So these points have already been covered. Now, contour the dissection with the regard of contour of the globe. So your crescent should not be like superficial at one point and deep at the other point. It is not going to be a good self-sealing incision then in creating more SIA. This is a pictorial representation of a deep dissection which could lead to scleral disinsertion. We can also go on with the surgery at this plane only, or we can change the site. This is a superficial dissection leading to buttonholing. So that is where lies the importance of going into half the scleral thickness. It should not be deeper than that. It should not be more superficial. And a deeper dissection leading to premature entry and iris collapse, leading to more and more complications during the surgery. DM detachment due to a blunt keratome, that has to be avoided. Now, to achieve emetropia, please calculate your personal SIA. Don't rely on the tables issued by others. Please calculate your own SIA for each incision. Center your incision along the steep meridian. Longer incisions produce more flattening. Posterior incisions decrease the SIA. Straight or frown incision are known to decrease the SIA. And scleral incisions they minimize the suture-induced astigmatism. Thank you for your patient listening.
Thank you, everybody. Thank you, ISMS, ICS.
So to make the session interesting, I will have a little interruption. We will invite questions so that we learn from you what we have to improve and what we have to do. Please.
Before anybody asks, I want to ask Dr. Ravi Trehan, in which patient would you do a customized small incision cataract surgery, and which patient you would just, would you customize each and every patient of yours?
Mike.
Every patient. So then, I think the 2-minute surgery is out. We have to debate what we need to work on now. So, who are in favor of faster surgery and who are in favor of customized surgery? So the need of the patient is the best. So, what do you want to go about? Sir, please take the mic and answer.
Sir, mic. Sir, please.
I was saying that if you have a number of cases, say you have to do surgery on 25 patients a day, so you must certainly be a fast surgeon. So it is the quantum of surgery that you have that ultimately will decide how fast you should be. At the same time, when you are fast, you should also ensure the surgery is also that much safe.
So you can't do a very, in 2 minutes you can't customize your incisions. You have to be,
Maybe we can, but there isn't any need. No, you are not going anywhere else. You have plenty of time. You have only 3 or 4 cases. You have all the time in the world. Why should you hurry?
No, it doesn't take much time, Puramani will...
Maybe we can reduce the present time.
I think Dr. Rakesh have to reply.
Yeah, the question was not directed to me, but technique was mine, customization. And for me, it is 2-3 surgery, not a day, but per week. So I can customize. But as far as Dr. Rakesh Shakya's this thing is concerned, 1 minute. In Chitrakoot, say they are doing such a large volume and they are doing a good humanitarian work. And for India it is needed. That's why they have to do very fast. But as far as the medico-legal practice is concerned, there is a recent, I think, Supreme Court judgment. There was some error committed by a physician. The physician argued in the court that we have to finish this much patients in OPD in this much time. So you cannot concentrate on the details. The court gave the judgment that you can restrict your number of patients. Whatever is justifiable for the patient, you have to do. You can stop seeing patient and you limit your number of patients.
Sir, I agree with I think what Dr. Rakesh is going to say. I already agree to it, but I don't think till now there is any conclusion as to what is really to be followed.
Dr. Ruchi, there is an association in Japan who tells you how to be slower in surgery. And there is no hurry. You should choose your patient and you should do, each eye is important. Even if you lose one eye in doing faster surgery, that would create a hell of a lot of problem.
Dr. Kamaljeet, you have a mic in your hand. I want to ask you, give us tips. How would you do a biometry in a silicon filled eye? You have a patient with diabetic retinopathy who has undergone RD surgery for tangential RD and you want to do an SICS. Please give us tips.
My resident would do this. I don't know much about how to do in silicon filled eye. Anybody can...
Okay, anybody from retina who wants to...
I just want to share, we can plan the things pre-operatively and then can speed up the things, not 2 minutes, but can reasonably, but pre-planned. Where the incision, how much, shape, size, site incision, and we can speed up.
I'll add one point to this thing. The time is not important at all. When you are in there, whatever situation comes in front of you, you have to handle it. And once you think of time and try to be a hero, you can end up in being zero. So you don't try at all to look at the time and do the best on the table. Because sometimes we have seen surprises which can't at this stage to happen. It is really belittling, but it happens. So the time is not a factor at all.
The time is not a factor, despite of it will be a factor.
Your name please.
In flows.
I'm Dr. G.S. Goga from Assam. I'm doing some of the SICS cases. In some of my cases, I found that there's some gapping postoperatively of the wound, but not in all cases. What's the trick of that incisional wound? Sometimes there is a gapping and sometimes not.
Your wound construction must be faulty.
What's the right correction?
No, if you are not using a sharp blade, as your blade should be good.
Yeah.
Many a time blunt instruments create zigzag.
So your corneal dissection has to be a little longer. If you have a very short corneal dissection, when you hydrate your wound, there is a propensity for your internal lip to evert. So
No,
that's the
I
trick.
don't hydrate the main one. Have I?
No. When you're constructing a triplanar incision, it's
No,
you
if
know,
the
the external and
scleral-
an internal incision. The internal incision into the cornea has to be a little longer. If it is shorter and your wound leaks, then there is a tendency for that kind of a gape which you are describing.
The scleral incision should not be too deep also. That can also cause gaping. If it is too deep, then that also leads to gaping in the wound.
All replied,
And too much of
except Dr.
cautery,
Rakesh.
that also leads to
The
problem.
fastest one I have ever seen.
So I think, sir, after the incision, you should, with the help of the creasing, grooving of the incision is very important. So when you did the proper grooving of the incision, then you can find the good incision, good depth of the tunnel.
No, not uniplanar. No.
The plane of the tunnel should not keep on changing. That means
That is-
while you are grooving the tunnel,
yeah.
many a times people go up and down, so the tunnel plane keeps on changing. So if that is smooth, then the opposition between the two lips, it's good. And for that, it's very important that you should have sharp instrument. Number two, your movement should be in one direction only, I mean, whatever we are doing.
Yeah, and the third point which Sir has already mentioned, if you tend to have a superficial outer lip, then there is a tendency of the wound to gap, and there is a little bit of slippage of the wound post-operatively, as Sir has mentioned. Maybe that can be a cause in your cases, Sir.
Going to lunch? I will join you.
Okay. Dr. Rakesh, you wanted to speak something?
Are there any precautions to be taken in post-vitrectomized eyes? Any precautions? Vitrectomized eyes?
In post,
I would like to give few suggestions for that. Vitrectomized eyes, as if there is silicone inside, and if there is no silicone inside, two things are there. In silicone inside eye, the globe will not collapse. So you have to give complete anesthesia in such cases. And in the vitrectomized eyes, moment you take the incision, the globe will collapse. Then there are two different scenarios in this situation. In siliconized eye, you must use anesthesia. The eye must be rock steady in such situation. Then only you can manage it, because otherwise eye will not become that much soft, and everything will start popping out.
use AC maintainer also in these cases.
Yeah. AC maintainer must. Well, if you remember a time when IOLs was were not being used in cataract surgery, in camp surgery, and then later on IOLs have now become the rule. In the beginning, people would say, "Acha, let's put a 21 diopter in this eye and a 22 diopter in that eye." You remember that time?
Yes.
But now we've gone on to doing biometry for each patient, and I don't see any reason why, with time to come, you'd be doing your pre-op astigmatic sort of calculation and saying this patient needs a superior temporal incision, this one needs a temporal incision, and so on. Because the only way you're going to get people to accept what you give them and to want to come back for more and to increase the CSR is by improving your results. There's no second way out. So I think we'll just have to work out how to do it better on a mass scale.
Anybody would like to share their experiences, any innovation somebody is doing and not being noticed? This is the forum where you stand up and say that I am doing this and we want to take you forward. This is...
Can I share my experience?
Yeah.
Okay.
Here, Hossam is a very famous doctor in Egypt.
First of all...
And he's sharing his experience. Yeah.
First of all, let me, sir, to thank you very much for having me on this prestigious dais. I'm Hossam Ziada from Egypt. I'm the president of the Egypt chapter of the International Society of the Manual Small Incision and Cataract Surgeon. And so I'm conducting the new perspectives now about the small incision, the manual small incision cataract surgery in my country and in my region, Africa and the Gulf. I have done the first case of small incision 12 years ago. Then I shifted to phacoemulsification and mastered it. I am now a phaco trainer, at the same time a small incision cataract surgeon and trainer in my university. So I'm believing for the cataract surgeon to be fully equipped, to be able to do extracapsular surgery, phaco, and small incision. And so I am teaching my residents now the all kinds and the all modes or methods of cataract surgery. Nowadays, I don't go for phacoemulsification in cataracta nigra and black and hard cataract, especially in the old patients, to save the time and save the cornea as well. Even I can do the cataract, the phacoemulsification in such cases, but with the experience, with time, and so optimization of the work, I'm believing now in the small incision cataract as a very good alternative to phacoemulsification in such cases, as well in all situations and conditions, but especially in the hard cataracts, especially if you are not sure about the patient's cornea, you have to go for the small incision cataract. I'm now doing it as a routine in all my cases with brown and black cataract with very good results. I have a patient last week before coming to All India, both eyes with densely brown cataract. I have done one eye with a small incision and the other eye with phacoemulsification. The small incision took about 5 minutes with very good result in the crystal clear cornea on the next morning. The phacoemulsification took around 15 minutes to keep it small pieces, to cool the back of cornea with viscoelastic every other minute to keep the endothelium for the next morning lock. So I'm advising all of the cataract surgeons to be fully equipped by all methods of the cataract surgery. And thank you very much.
Thank you, sir. And with this, we have come to the end of part A of Magic of SICS1. So I would like to call upon the next set of chairpersons. We would like Dr. Amulya Sahu to continue as the chairman. We have Dr. Prakash Marathe and Dr. Ranjit Dhaliwal as the co-chairman, Dr. Kamaljit Singh for the convener, and Dr. Ravi Trehan for moderating the session. Thank you so much.
Prakash.
I was there in elections, so I requested. बस बैठो सर इधर हाँ बैठो ना आओ सर हमारा कॉपी किधर है